Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Expert series of video podcasts, we have Dr. Surbhi Sidana, who is going to talk to us about a major presentation she made at the International Myeloma Society meeting that just concluded in Brazil. And she's going to talk to us about Ciltacabtagene for relapsed refractory myeloma real-world experience. We're privileged to have her. Welcome, Surbhi.
Thank you, Ravi. It's my honor to be here discussing this with you.
So, can you give us a little context as to what exactly you did in this study that you presented?
Sure. So Ciltacabtagene, as the audience is familiar with, is an autologous BCMA-directed CAR T that was the second FDA-approved CAR T in myeloma. It was FDA approved in 2022. The label has now been expanded to earlier line use. But when we treat CAR T patients in a clinical trial, the criteria are so stringent. You have to be progressing, but not fast enough so that you can get a slot. You have to have perfect organ function, perfect counts. And so when this was approved, we were very excited with the results of the CARTITUDE-1 trial, 98% response rate, 83% CR rate, and a median progression-free survival reaching 3 years, right? But we asked ourselves, how will this translate into the real-world practice that we all have where patients do not meet those perfect criteria? The average age of a myeloma patient at the time of diagnosis is 69. By the time they relapse, it's much later. They often have other comorbidities. Often the blood counts by the time they're heavily pretreated are lower. Performance status is not ideal. So can we treat our everyday patients with this therapy, and what kind of benefit or risks will they have with it? And that's why we put together this. It's a gigantic effort with over 16 centers involved from the US Myeloma Immunotherapy Consortium. So it's just not my work. I had the privilege of presenting this and putting this together on behalf of many colleagues. And we evaluated over 250 patients who underwent apheresis and then followed their journey forward to look at efficacy of Ciltacabtagene as well as safety and other outcomes.
So can you tell us about the cohort of patients that you studied?
Sure. So we looked at 255 patients who underwent apheresis with the intention of manufacturing Ciltacabtagene. As the audience knows, the first step in CAR T is apheresis of lymphocytes to manufacture CAR T, a process that can take several weeks. And at times, patients drop out because either their disease progresses or something happens and manufacturing is not successful. And with the CARTITUDE-1 trial, they only evaluated outcomes in patients who actually proceeded to CAR T. And so we also wanted to evaluate how many patients didn't proceed. And this was not very different than clinical trials. About 93% of patients were eventually able to get CAR T, similar to trial cohort. 19 patients did not receive it, primarily due to disease progression. Manufacturing failure was about 6% at first attempt, but eventually was just 1%. And I will say this, right? This has been an issue with Ciltacabtagene, as you all well know, is that out of specification product rate. So what is an out of specification product for the audience? It is when the FDA criteria for release of a product are not met. The products have to have certain dose levels, certain viability, certain activation of markers. When any of those criteria are not met, it's an out of specification product. And in fact, the criteria for commercial products are even more stringent than they were on the clinical trial. So about 19% of our patients were treated with an out of specification product on an expanded access protocol. And in 2022, there was a shortage of fludarabine. So Flu-Cy, fludarabine Cytoxan, is the standard lymphodepletion regimen that has been used in all trials. But suddenly we were all faced with a shortage. So about 19% of patients received other lymphodepletion regimens. I mention this because this might impact safety and efficacy since the trial conditions use, fludarabine and Cytoxan, and the product might have looked different in an expanded access protocol. So we will evaluate outcomes by 3 cohorts in this study: all patients, the ones who received a conforming product, and then a subgroup that received a conforming product and Flu-Cy.
So what do you have to tell us about the results?
Yeah, so the results, right? So we had about 255 patients apheresed, 236 infused, and not surprisingly, over half of the patients in both the apheresed cohort and infused cohort would never have met the trial eligibility criteria. And this is not unique to this real-world study with CAR T. We have seen this before with ide-cel. We've seen this before with lymphoma. CAR T studies, that are patients that we see in everyday clinic. They have comorbidity. So the main reasons were organ impairment, cytopenias. About 15% had prior BCMA-directed therapy, which was not allowed in the CARTITUDE-1 trial. And performance status was also an issue in over 10% of patients.
And so, what can you tell us about the characteristics of the patients compared to the CARTITUDE study patients?
Yeah, so on the left-hand column here is the real-world cohort of 236 patients who got infused. And on the right-hand column, for comparison, although it's not a direct comparison, just for reference, is the 97 patients in CARTITUDE-1 who got infusion with Ciltacabtagene. As you can see, these were patients in their 60s. In this real-world cohort, 11% of them were Black and 8% were Hispanic. High-risk cytogenetics, like we defined with deletion 17p, translocation 414, and translocation 1416, were seen in 39% of patients. And for reference, this was 24% in CARTITUDE-1, so numerically slightly higher. When you look at extramedullary disease, and this is true extramedullary disease that excludes plasmacytomas that are contiguous with the bone, and this is how it was defined in CARTITUDE-1 as well, it is 26% of patients compared to 13% of patients in CARTITUDE-1. The median prior lines of therapy was 6. Most patients had received a prior auto transplant. 30% were parental drug refractory, which is refractory to 2 PIs, 2 IMiDs, and an anti-CD38. And 14% of patients had received prior BCMA-directed therapy.
And what can you tell us about the safety?
Right, so half of the patients were not trial eligible, they were heavily pretreated, and yet we saw that the safety profile was consistent with what we had seen in the trial, at least for immune-mediated toxicities. So cytokine release syndrome was seen in majority of patients, 75%, and was grade 3 or higher only in 5% of patients. The median time to onset was 7 days, consistent with trial data. When you look at ICANS, or immune cell-associated neurotoxicity syndrome, it was seen in 14% of patients and grade 3 or higher in 4%. Now, we all know that Ciltacabtagene is more likely to be associated with delayed neurotoxicity than other BCMA-directed CAR T. So this was of particular interest to us. And this was seen in 10% of patients, though thankfully, Parkinsonism, something that we worry about a lot, was only seen in 2%. The most common delayed neurotoxicity was cranial nerve palsy involving the 7th nerve. And infections were also seen about 21% of patients with severe infections, similar to CARTITUDE-1.
What else can you tell us about what you saw in terms of side effects?
Yeah, so non-relapse mortality or death from reasons other than myeloma progression was seen in about 10% of patients. And the most common cause of death in this situation was infections followed by immune-mediated toxicities. I think this is sobering, right? This is also numerically a little bit higher than what was reported in the trial and tells us that we have an area that we need to intervene on to prevent infections and severe infections that can lead to death. So I think this gives us data that we can intervene on this, and hopefully this, as we move things to earlier line and as we're doing CAR T in not so emergent situations where disease is exploding, hopefully this can also get better.
What about secondary primary malignancies?
Right, so that is also a very hot topic, right, with CAR T. And second primary malignancies with this 1-year follow-up. So our median follow-up is 13 months, and it's important as more time goes on, we might see more cases, is about 8.5%. When you exclude non-cutaneous, just the cutaneous squamous cell cancer or basal cell cancer, it's 5.5%. We had about 3 cases of myeloid neoplasms or acute leukemia and 1 case of T-cell lymphoma. And when you compare it to CARTITUDE-1, when they had reported their data at 1 year, the SPM rate was about 7%. So this is tracking with what we've seen in CARTITUDE-1.
And now for the upside, how did this do in terms of efficacy?
Right, so this is where we were all very interested in. The results seen in CARTITUDE-1 were so remarkable, and we wanted to see how this was held up. And so as you can see here in figure 8, this is 3 different population of patients. We've summarized this in the table here. Is the entire infused cohort and then the conforming cohort and conforming cohort with flu-cy. So I'll break it down. In the overall infused cohort, the response rate was 89% and the CR rate was 70%. And when you look at the conforming cohort, the response rates were slightly higher at 94%, and the CR rates were 74%. And we compare it to CARTITUDE-1, this was 98% and 83%. I think what was also essential, as you can see here in figure B, is for patients who were in complete response and evaluable for MRD, most of them were MRD negative, 95%, suggesting that the responses, when you do achieve them, are deep responses that are MRD negative, which is excellent to see.
And how durable are these?
Right. So median follow-up, as I said, in our study was about 13 months. And with this, the median PFS has not yet been reached. The 1-year estimated PFS of the infused cohort is about 68%. And in the conforming cilta-cel cohort is about 72%. When you compare this to what was reported in CARTITUDE-1 with their earlier follow-up, the 1-year estimate was about 77%. So it's tracking in the same direction, although maybe numerically a little bit lower than what was seen in CARTITUDE-1. Again, this is very encouraging.
And obviously, one of the hot areas that is talked about is sequencing of these therapies. And so what did you find in this trial with the sequencing?
Right. So 14% of our patients were pre-treated with BCMA-directed therapies, most commonly ADC. Some patients also had exposure to bispecifics and CAR-T. And not surprisingly, we found that the overall response rate in this cohort was lower and PFS was lower. So the overall response rate here was 70%, CR rate was 42%, and the median PFS was only 13.6 months. We did not see any difference in PFS based on the type of prior BCMA-directed therapy. Again, this was not surprising to us. We've seen similar data in a 20-patient cohort with CARTITUDE-1 cohort C, CARTITUDE-2 cohort C. But I think the story that emerged is more about the timing and the interval, as you will see on the next slide, that can help inform real-world practice. So if you would forward one slide, I would be happy to share that.
Sure.
Right. So what we have realized is that timing may matter in terms of the last exposure from prior BCMA-directed therapy. So just under half of our patients had less than a 6-month interval from end of last BCMA-directed therapy to receiving cilta-cel. 55% had 6 months or greater. And what we saw was when the interval is less than 6 months, the response rates and CR rates are much lower. The overall response rate were 54% compared to 94%, and the CR rate was 31% compared to 56%. Similarly, PFS was only 6 months if you had less than a 6-month interval versus 16.8 months. Now, many factors may contribute here, including downregulation of BCMA. This might also be an impact of maybe these patients didn't have options, had more aggressive disease, and some of that is bias of retrospective data too. But this is a theme that is emerging not just from this study, but from other studies too. So if we have the ability to bridge these patients with something else before they proceed to CAR-T, I think that would be ideal.
And what can you tell us about subset analysis?
Right. So, subgroups of interest, of course, are high-risk cytogenetics and patients with EMD. And historically, they've done poorly, and not a surprise that they had inferior outcomes compared to patients who didn't have these high-risk features. But you can still see the outcomes of these patients compared to historical data are still pretty good. Those who were CARTITUDE-1 ineligible also had inferior outcomes compared to those who were CARTITUDE-1 eligible. Age did not seem to have an impact. People above 70 did just as well. And the different type of lymphodepletion therapies, at least on this analysis, did not seem to have an impact with cilta-cel. The story with ide-cel is a little bit different, as we've presented previously. When patients with ide-cel got alternative lymphodepletion therapies in our CIBMTR analysis, they had inferior outcomes. So I think the story in lymphodepletion will continue to evolve in the coming months and years.
And what can you tell us about the survival?
I think overall survival, similar to what we've seen for PFS, is tracking in the right direction as what we've seen with CARTITUDE-1. Similar, maybe a few percentage point lower. Again, median has not been reached. The 1-year estimate is 82% in the infused cohort, 86% in the conforming cohort. And for CARTITUDE-1, the reference at that time was 89%.
And I believe you did some nifty analysis on predictions. So what can you tell us about your analysis on prediction for survival and progression-free survival?
Right. So we did a multivariable analysis. We had a large cohort that allowed us to study different factors and if they were independently associated with inferior outcomes. And what we found was there were not many surprises. There was maybe one surprise. So prior BCMA-directed therapy was borderline significant. Perhaps if we had a larger sample size, this would have become statistically significant for inferior PFS. Patients with high-risk cytogenetics and extramedullary disease had both inferior PFS and overall survival. None of this is surprising. I think what was a little bit not surprising, but a unique thing that is emerging from all of the upcoming data is baseline ferritin right at the time of lymphodepletion therapy with a cutoff of over 400, which is upper limit of normal. If you have that, outcomes were inferior independently, of everything else, both for PFS and OS. Now, this is a theme that's emerging in lymphoma as well. We don't understand the biological underpinning, like what is driving this. Is this a marker of bad disease? Is this a marker of inflammation? I think some more to come, and perhaps this is something that can be targeted in the future if we understand what's driving this.
So what are the main takeaways for this large cohort of patients that you presented?
Right. So, just in summary, what we found was in this large cohort of patients treated at 16 different centers, that Ciltacabtagene administration is feasible, even though the real world patients are not, the most robust in terms of eligibility for trials. We had high response rates, 90 to 95% that were deep and durable, at least with this 13-month of follow-up. And the toxicity profile that we saw was consistent with clinical trial data, with one emphasis that the non-relapse mortality is 10%, mostly driven by infection. So that's an area we can really intervene with better supportive care, more aggressive supportive care. And of course, we saw that prior BCMA-directed therapy, especially patients receiving prior BCMA-directed therapy within 6 months of administration of Ciltacabtagene, had inferior outcomes. And this gives us some clues on how we might sequence therapies in the future.
Well, I wish to thank you very much for taking the time to talk to the audience about this excellent work that you've done. And this is something that I congratulate you for. I hope that I can have you back on a future program to talk about the additional research that will surely come from yourself and your colleagues.
Thank you so much, Ravi. And if the listeners are interested, the paper from this presentation is now online at Blood, where more details can be found.
Oh, great. Congratulations once again.
Thank you so much.